Good morning, all, and thank you for joining today, particularly all our witnesses. Thank you indeed for helping us with this important inquiry. We want to learn from you about the long-term consequences of people who suffer from COVID. Thank you, and welcome to our witnesses for the next session. I presume you're all there, so if I might start straight away. And Professor O'Donoghue, you're going to go first.
Thank you very much for the invitation to join you today. I'm a kidney doctor in Salford. I'm also the Registrar at the Royal College of Physicians, and I'm chair of Kidney Care UK, the patient charity. I'm also chair of the ISN advocacy group and immediate past president of the Renal Association, and I was the National Clinical Director for Kidney Care from 2007 to 13. And there are probably 4 points that I want to make. Firstly, that kidney disease is common and harmful and very much related to COVID, but it's silent. The second, and where I'll give you most of the information, is the impact of acute kidney injury, acute renal failure in COVID. Of course, people with kidney disease are also affected by the delays to restoration of normal services and the disruption as other services. So 85% or greater reduction in referrals for a period of 3 months and disruption almost completely to transplantation for a period of time. Good to see that that's back up and running, but live donation, which carries additional risks for live donors as well, requires greater infection prevention control measures, is still slow to get started, and half of all our donors are live donors these days. So that's a major issue, and of course a large part of the kidney population shielding because of the high risks to them with COVID and the consequences of that as they play out. Obviously that's similar for other patient groups as well. And perhaps an important point, given the conversations just now, people with kidney disease are often excluded from clinical trials. So the vast body of research in cardiovascular studies excluded people with kidney disease for many years. I think that's starting to improve now, but I was disappointed to read last week that 45% of all intervention trials exclude people with kidney disease, and there's really no good reason for that. It's almost ignorance. So kidney disease affects around 15% of the adult population in the UK, according to Health Survey for England, associated with age, with BAME. Non-Europeans have very high rates of kidney disease, sometimes up to 6 times the rates in the Caucasian population. The global burden of disease is about 850 million people, and by 2040 it will be the 5th most common cause of years of life lost, and that's chronic kidney disease. Acute kidney injuries often thought of as a condition that the kidney shuts down and then repairs and recovers from, and that's what I was taught in medical school, but I think it was still taught a few years ago in that vein. However, 16% of all people admitted for non-elective admissions in normal times develop acute kidney injury in hospital. That's about 500,000 people, and we know there's a similar number in the community that don't get admitted to hospital. 12% of all people who develop acute kidney injury and require dialysis end up on renal replacement therapy within the next 5 years. So that's the background to it. And really, kidney disease dwarfs other risk factors for severe outcomes, hospitalization and death, apart from age. So in all the various analyses and the elegant work that Julia Hipsley-Cox is doing, that's the disease factor that comes out very enormously. Similarly with the MRC stratification study that was reported over the weekend. And apart from respiratory disease, it really dwarfs other organ systems in terms of impact. So just some data from King's that is reflected in other published data sets. So at King's, around about 1,000 patients, 58% of them had pre-existing kidney disease. 40% developed acute kidney injury, and the mortality in those was 42%. And it's studies from New York, 50% mortality in the acute kidney injury group versus 8% in those who don't get acute kidney injury. So really quite staggering. And then in terms of long COVID, what is the recovery? So back to that King's data, 36% of those that survived their acute kidney injury didn't return to their previous level of kidney function. So what will happen to those patients over time is a key research question and a key service delivery question, I think. So I'll stop there.
Thank you very much indeed. Professor Brandner?
Yes, good morning. I'm Sebastian Brandner. Can everyone hear me?
Yes.
Yeah, Sebastian Brandner. I'm Professor of Neuropathology at University College London, and I'm Honorary Consultant Neuropathologist at the National Hospital, which is part of University College Hospitals. I'm an elect member of the English Regional Council at the Royal College of Pathologists. So I would like to give you an overview of what happens in the central nervous system of patients who suffer from or died of COVID-19. So the central nervous system, as is brain and spinal cord, are involved in a proportion of patients with COVID-19. And to give you an idea on the frequencies, I quote a study of over 3,200 COVID-19 patients. There's a study from New York University, which were all admitted to hospital. So 3,200 patients admitted to the hospital. Of those, 450, that's 14%, had brain imaging during the inpatient stay. And of all those patients with imaging, 38 had some form of stroke in the brain. So that's 1%, 1.2% of those 3,200 admitted to hospital. So it's not a very large number, and a fatal outcome was seen in approximately half of those admitted. So 1 in 150 admitted to hospital had a fatal outcome related to CNS complications. Other studies that have looked at similar numbers, similar frequencies, have been reported 1.5, 2.5% of strokes. So I would like to explain to you a bit more what happens in the brain. First of all, to say we as pathologists in this context, we have seen only very few of those patients with complications. Of course, most of the complications are survived, fortunately, but also, and that's the disadvantage or the downside, there's very limited availability of post-mortem exams of the brain. During this entire COVID-19 outbreak, we had only just over a dozen or perhaps 2 dozens of postmortems with available brains for full analysis. So there's currently no large postmortem study around with more than 1 or 2 dozen brain autopsies. None of those have been published, and those which have been published, however, show all recurring findings in the central nervous system. I would like to explain those now. The complications that we found in COVID-19, they all occur in the context of systemic disease. We heard a lot about the systemic diseases, and the complications are acute ischemic stroke, so lack of oxygen to a perfusion problem in the brain, but also inflammation of the meninges and the brain and spinal cord, so that's called meningoencephalitis. So microbleeds, as well as a diffuse leukoencephalopathy, and that is a disease of the brain white matter. So let's start with the common ones. The disturbances of the blood clotting in COVID-19, so we heard a lot about this in the previous session. They can obviously cause varied amounts and sizes of blood clots to enter the brain circulation. And the blood clot entering the brain circulation causes a stroke, an infarct. And depending on the size of the clot, it can be a very, very small infarct, microinfarct, that can be seen practically only under the microscope on tissue exam. up to very large regional or global strokes, which are usually then a cause of death. So we have seen such strokes of small and also very large sizes in the brain. And these strokes can be associated with hemorrhages, so bleeds of varied sizes, which again are caused and often also aggravated by these systemic clotting problems, which can also be aggravated by certain treatments. In the previous session, we heard something about ECMO, which is done for oxygenation of the blood, but this can also aggravate clotting problems. The other complication that cause disturbances of the brain are the lung complication. All the respiratory problems in patients with COVID-19 can potentially cause a lack of oxygen in the circulation, including the brain, and that's a condition called hypoxia. And hypoxia in the brain causes the death of nerve cells, often in a very diffuse distribution. Finally, another complication in COVID-19 is brain inflammation. So this inflammation is thought generally to occur in the context of systemic disease. And brain inflammation is a common manifestation in multi-organ failure, so kidney, liver, heart, all the things that we heard about previously. And regardless of the cause, so the brain inflammation is not necessarily specific to COVID, but a term that has been often brought into this context is the cytokine storm, which is a massive and probably inappropriate activation of immune response. And we think that some of the unusual findings in the strokes in the brain are related to such a cytokine storm. So among those brains that we examined, we found that some of the areas in their strokes showed a very severe and very unusual inflammation. So it is thought that this immune response can trigger some of the inflammation in the context of the strokes. So we have also seen much milder inflammation in the meninges. So the meninges are the membranes covering the brain and in the brain itself. And this has always correlated really well with the imaging findings. What is currently not very well established is the role of the virus itself in causing direct effects. So it's thought there might be viral entry into the brain via blood vessels or directly by docking onto the receptors of the surface of the brain cells. But it's actually thought that this has probably no major role, and instead that the CNS complications of brain and spinal cord and the meninges are secondary to systemic illness rather than direct viral brain invasion. So conclusion, there's not a single cause of brain involvement, but there's a range of systemic conditions that cause the brain complications. And the most important complication, to sum it up, of COVID in the brain are strokes, hypoxia, and inflammation. Thank you very much.
Thank you very much indeed. Professor Solomon?
Thank you very much. My name is Professor Tom Solomon, and I'm the Director of the National Institute for Health Research, Health Protection Research Unit in Emerging Infections. I'm also Professor of Neurology here at the University of Liverpool and the Walton Centre NHS Foundation Trust. I head a large research team who have been working on emerging infections for many years, and particularly those that impact on the brain. And our emerging infections research on COVID-19 started in mid-January, actually, before it was even called COVID-19. And we supported the setup of the large ISARIC clinical characterization protocol, which is the largest study in the world looking at hospitalized patients. It's studied more than 70,000, and it's given us much of this important information on risk factors for particular patients and what their outcomes might be. Now, as we heard from earlier witnesses, we initially thought this was going to be a respiratory disease, but it's become clear now that it does affect all parts of the body, including the brain, as we've just been hearing about from Professor Brandner, from a pathological viewpoint. I'm going to provide more of a clinical perspective. And in particular, I'm going to talk about three aspects which have important long-term health implications and I think have important questions for this committee to think about. So firstly, COVID-19 causes neurological diseases such as stroke, as we've been hearing about, also delirium, which is confusion in patients in hospital. And one cause of this is encephalitis, which is inflammation of the brain. Sometimes this is directly due to the virus. More often it seems it's an indirect effect of the body's overall response to the infection. The stroke is especially common. We've led some studies from Liverpool both across the UK and also global studies looking at comparative data. And it's clear that stroke is the most important neurological problem that we're seeing. So we need to think about how we can prevent patients with COVID-19 developing strokes, and indeed those who have had a stroke, what do we need to do to make sure that they don't have subsequent strokes afterwards, because this is often a risk factor after somebody's had one stroke. Now, the other really important thing for all these patients with any neurological complication of COVID-19 is rehabilitation of those who've had long-term illness. And there's some fantastic work done by the NHS in conjunction with charities like the Stroke Association, the Encephalitis Society, but more work is needed in this area. Rehabilitation is going to be a big issue. It already is. Now, the government announced some CECOL rehabilitation centres a few months ago, which will be specifically for COVID-19 patients. But in the last few days, there's been some uncertainty about how much actual cash there will be to support capital build of new centres and to support refurbishment of centres. So this, I think, is something important that we need to keep an eye on. The second group of patients are those who've had COVID-19 infection and it's caused mental illness. And this can range from frank psychotic episodes in hospital to those who are suffering from anxiety and depression after they've recovered. We've heard quite a bit today about long COVID, and this includes not just the physical problems like breathlessness, but also mental health problems, anxiety, depression, and then potentially neurological problems, muscle pain, fatigue, etc. And GPs are calling for patients to be assessed. They're seeing lots of patients now with these problems. This is really the current epidemic in primary care. They're seeing lots of patients who are left over with problems from their COVID, and they need to be able to refer them to get help in understanding what's going on. Now, in Liverpool, for many years, we've had a combined clinic and neurological infectious disease clinical service, which would look at patients like this. But across the country, there's not much of a service provision for this kind of patient. And in fact, in the UK, we have one neurologist for every 40,000 patients. This compares with across Europe, where it's one neurologist for every 15,000 patients. The third group I want to think about are people who were not infected with COVID-19 at all, but have still been seriously affected by the pandemic in terms of mental ill health. And again, this is probably even a bigger number than those who were actually infected with the virus. Mental health services, as we know, have had chronic underfunding. And potentially this now is a chance to really review the support that we give people with mental health problems, from children all the way through to the elderly. I'll stop there.
Thank you very much indeed. That was extremely helpful. So can I just start with my colleagues now? And again, if we keep questions as brief as possible and answers to the point, I might get through a lot of questions, which I have no doubt we'll have. Alice Meninges.
Thank you, Lord Chair, and thank you for our witnesses. That was a very interesting session. I've really got a general question which has two parts. We've heard of a very wide range of symptoms in long-term COVID, and I have two parts to my question. How much of that is explicable by what we already understand of the disease? And how much is still very not well understood, on which, for example, you might like to focus research if the resources were available? So where are the biggest gaps on which you'd like some answers, where money could be focused if it was available? Thank you.
Could I start with that one?
Please. Yes, please, Professor Solomon.
Thank you. I think it's a good point. I mean, one thing that has characterised the UK compared with the rest of the world is the research response has been fantastic. We've had incredible support from the government and other funders to do the research. And this is why we lead the world with programmes like the Asymptomatic programme, the FOST-COVID we heard about earlier, the treatment trials, which are answering really important questions like steroids. And I've no doubt that our vaccine work also will be world leading. But there are some surprising gaps. And actually one of these gaps is interestingly on the neurological disease. So we don't yet have any specific large funding programs in this area, although I must declare an interest. We're currently in the middle of an application. But I think you asked about which symptoms are explicable and which are not understood. And I think some of these neurological problems where we don't actually find the virus is in the central nervous system, but we need to understand how the infection has triggered some of these problems. That's one area which I think we still need to focus on.
Thank you very much. Professor, either of the other two witnesses.
Yes, so Professor O'Donoghue here. So yes. I think that the people who've been shielded are a particular group, and the impact on those individuals, I think, is an area that's well worth studying. And the majority of patients who get COVID have a range of comorbidities, as we've heard from a number of people today. So I think any of the research needs to be comprehensive in terms of the populations that it looks at, and not exclude people because they've got a range of disease processes that makes it more challenging to investigate issues of fatigue and psychological anxiety, depression issues. It'd be important that we don't exclude people in our research studies.
Thank you. Professor Brandner?
Yeah, so from our perspective, it would be important to understand how the disease affects the brain. To do this, we obviously need material to study the effects of the brain. Yes, there have been amazing studies on clinical radiological correlation. These have provided fantastic insight into the disease pathogenesis, how the systemic effects of COVID-19 can affect the central nervous system. But very often, this is where it ends. And the gap here that we see from a pathology community, there was a fantastic and enthusiastic response from pathologists, but very often not enough patients who died of COVID-19 related illnesses with or without central nervous system involvement have actually undergone autopsy, despite the availability of mortuaries. But there was often a reluctance from NHS hospitals, understandably, because they had to divert resources to the treatment and to the management of these patients. But yet, we are seeing that the 1918 pandemic, which had a remarkable lack of post-mortem material to study, has repeated itself. And I think there are still opportunities, but this is something would be important to address that, in particular now when we're in a more balanced position, that resources have kind of readjusted. Mortuaries are not overwhelmed with people who are dying of any type of complications. To facilitate this sort of research, and this would be really important to understand the pathogenesis on the central nervous system.
Thank you very much.
Thank you very much. Viscount Ridley.
Thank you, Lord Chairman. I realise that Professor Brandner and Professor Solomon are neurologists and not psychologists, but still we have already touched on fatigue, anxiety, depression, and other mental health effects as a result of COVID-19. Can you say or speculate about whether these are direct effects of the disease, either through fatigue or direct physiological consequences, or whether they are mostly the indirect effects of lockdown? And are they confined to those who've been in hospital, or are we also seeing the effect in the community? And when will we be able to say whether or not there has been an impact on the statistics of suicide?
I'll go first again if
okay, please.
I think that's a really important question. I think it's an unanswered question. We don't know the extent to which the big mental health, maybe epidemic's too dramatic a word, but we're certainly seeing a lot of mental illness. We don't know the extent to which that is directly related to the virus. I think the fact that we're seeing quite a lot in people who have clearly not been infected with the virus perhaps does indicate to us, it does tell us that a certain amount of this is just because of the effects of the pandemic on people's normal activities, the effect of lockdown, not being able to interact with people, difficulties with exercise, etc., etc. So I think some of it is that, but it's a really critical question about whether this virus, either directly in the body or indirectly through the body, through causing things like cytokine cascades and other aspects, is leading to some of these mental health issues. These are the kind of questions that we want to be addressing.
Thank you very much. Does anybody else want to come in?
I think it was very well put. I think I can't add anything to that. And just for the record, I'm not a neurologist, but a neuropathologist, which is still a little bit further distant from the psychology.
Well, I was always taught pathology is always at the last word and the answer. Why can't Ridley?
Thank you, Chairman. I do apologise for calling Professor Brandner a neurologist and not a neuropathologist.
Have you finished, or you?
Yes, I finished. Sorry.
Okay. Is Baroness Rock?
Thank you, Lord Chairman. I'd like to just ask two questions. One is further on the mental health services, and what data is being used to capture the provisions around what is needed in terms of mental health services. And perhaps Professor Solomon, if you could just give a little bit more detail on that. And just taking the data question a bit further as well, what are the barriers that you're finding are there in gathering data reliably in terms of the wider effects of COVID? Perhaps Professor Solomon could start.
Okay, thank you. Well, again, I should preface my answer. I'm not a psychiatrist or a psychologist. I'm a neurologist, but I don't want to duck the question, so I'll give you the best answer I can. I think in terms of mental health services, I think mental health services have suffered even before this pandemic. I don't think that's a secret to anyone that mental health has increased in recent years and the service provision has not. I think to capture data in terms of what is needed, my understanding is that this would just be about looking at waiting lists. But part of the worry with that is that sometimes people are not even put on waiting lists. If you know there's no service or you know it's going to take more than a year to see someone, then to some extent people will just not bother. They'll either try and sort things out privately or they'll not be able to get help at all, which I think is not a great situation. But Donal O'Donoghue, from a Royal College of Physicians perspective, maybe has a different view on the broader provision.
Professor O'Donoghue, more widely.
So I think Tom's right that the provision in mental health is poor and patchy, with long delays and challenges both in serious and enduring mental health and also lesser degrees of mental illness that can be quite catastrophic for people. I think we've got an opportunity to think about providing more holistic care than we have done previously. We're mainly dealing not just in a COVID world, but in the world we are in this 21st century. We're mainly dealing with people who have a number of conditions, and certainly in the kidney world, it's very unusual to see somebody who just has kidney disease, and if they just have kidney disease, a short time after that they will develop vascular disease and all the other complications. We see that in cancer and so on and so forth, and we know that the burden of minor mental illness, anxiety, depression is very high in those with long-term conditions, and we know that it has a very big impact on the amount of resource utilization and their clinical outcomes. So I think there's a real opportunity to work harder about parity of esteem, and that's been on the cards for a long time, but we need to shift the needle on that, and maybe with the resource constraints and the capacity constraints that come from the situation we're in with having to have infection prevention control measures in place. Maybe one of the things we can try and major on is actually more integrated approaches. Thinking about the challenge of the follow-up of all these people who've had COVID, both in the community and in hospital, and the capacity constraints in primary care and secondary care, we really need to work hard at integrating the data and ensuring that it's a one-stop shop for most people most of the time, and why can't that involve mental health issues as well, and signposting and so forth. That's quite a radical change from how we've siloed things in the past, but I think we do need to do that, and it's likely that if we can do that, that we will get a benefit in terms of both the population to study for research, but also being able to implement the things that we know now that we're not doing, as well as find new treatments for these affected populations. We have really no idea what the long-term consequences for respiratory disease and for kidney disease and for the major organs affected. What is the outcome here in terms of end-stage renal failure, or in terms of respiratory failure over the next 5 years? It could be a considerably greater number of people than we see developing those end-stage organ disease conditions in normal times.
Thank you very much. Baroness Rock, have you finished?
I finished. Thank you, Lord Chair.
Thank you. Okay. Baroness Shear.
Thank you, Lord Chair. May I ask what evidence there is that neurological issues can occur in mild or asymptomatic cases? And which of the neurological effects of COVID-19 will have long-term health implications? And within that, I wonder, Professor Solomon, you mentioned the importance of dedicated rehabilitation centres, given the multitude of organs that can be affected. Can I just ask each of you to say a little bit more about whether the capacity within the NHS is showing signs of preparedness to deal with these patients suffering from longer term COVID-19 effects, and whether these specialisms such as physios, occupational therapists, those professionals and essential support staff are there.
Thank you. So the first question, in terms of mild or asymptomatic neurological disease, if somebody has brain disease but no symptoms, you won't know about it from anything that they report in terms of how they feel or bits of their body that aren't working. But you pick it up from other types of research approach. So the New York scanning project that we heard about earlier from Professor Brandner, that was 3,000 patients who had brain scans done, and just over 1% of them had evidence of a stroke on the scan. So it was like a mini stroke. It was not something that caused them to have weakness in an arm or a leg. But when you did the brain scan, you found that there was evidence of we would use the term subclinical stroke. Now, you would find, if you took 3,000 people off the street and did brain scans on them, you would find evidence of vascular disease, mini strokes, and in particular, depending on the age of the population. You have to take such findings in context, but those are the kind of approaches that will tell us there has been damage, if you like, without the patient being aware of it. You asked about the dedicated services. I mean, this is what the Royal College of General Practitioners are calling for, in terms of specialist clinics that will deal specifically with the consequences of COVID-19. And as Professor O'Donoghue was saying, I think this might be an interesting approach, where traditionally we think of clinics for neurological problems or respiratory problems or kidney problems. It's quite rare to have clinics that are combined. And certainly we do our brain infections clinic, which is infectious diseases and neurology combined, but to have a service that also combines, say, respiratory disease and renal disease, it would require quite a shake-up, but it is quite a novel way of thinking about it. I think, and finally, you asked about the capacity, physiotherapists, occupational therapists, etc. These people are absolutely key to getting you back up and on your feet if you've had a stroke. Their service is hampered anyway, because currently everything that anyone does in the NHS has to be COVID secure, if you like. We have to make sure the patients don't have the virus. We have to make sure everybody is protected. So that already is like operating with one arm behind your back in terms of capacity. And but increasingly, I think people are looking at innovative ways of doing things. I was chairing one of the UK Research and Innovation Committees that was funding research across the country. And we were supporting very innovative projects, for example, looking at how you can do physio and occupational therapy remotely, how you don't need to be with the patient all the time, how much of it can you do with an iPad or Zoom, etc. So I think this pandemic is, obviously it's a terrible thing in many, many ways, but some of the things that may come out of it are new ways of working, which may be helpful in the longer run.
Thank you very much. Thank you very much indeed. Are you done?
I would echo those comments about that.
Okay.
We need to think about new ways of doing things. The workforce shortage is just so short in rehabilitation.
So in relation to Brandner's question and answer that we just got from Professor Solomon and you said before, Professor Donal, what has the College of Physicians that represents 27 different disciplines in medicine and the Royal College of General Practitioners, have they done any work and produced any papers to suggest what kind of care post-COVID people should have and where and by whom?
So we have produced some work on how we can work more closely together and support people with new ways of working. I can send the details through.
That'd be very good if you don't mind sending it in, because that might help answer Brandner's question, which is a good question. Brandner?
Yes, I did just want to ask a quick follow-up question to Professor Solomon, who I see has a specialism in emerging and zoonotic diseases. And that is there anything that COVID-19 has manifested itself as having surprised you?
You could put the question the other way around. Is there anything that's not surprised me? I think, I mean, we've known, so I work in emerging infections, and we've known about a pandemic, that it could happen at any time. I have on the back of my door, there is our business continuity plan. And I checked, and yes, indeed, pandemic was on there. But I think there's a big difference between theoretically knowing something could happen and then it actually happening. And a pandemic of this scale, I mean, we've had other flu pandemics. The last one was 2008, but it proved to be a pretty mild, weedy virus that didn't cause anything like the problems that this SARS-CoV-2 is doing. So, you know, this is a first for me, as it is for, I think, everybody living through it. So it's almost a new surprise every day. I think someone in my team actually, you know, I wear two hats. One is a sort of emerging infections hat, and one is the neurology hat. And somebody in the team early on said we should think about this respiratory virus causing neurological problems. And I was kind of so busy dealing with the problem that was definitely facing us that perhaps we were a little slower getting onto the neurology than we should have been. Yeah, I mean, it's a question that you could answer. You could spend an hour answering it and 2 hours discussing it, but I'll stop there.
Okay, thank you very much indeed. Baroness Walmsley. Baroness Walmsley.
Thank you. I have two questions. One is specifically for Professor O'Donoghue, and the other is more general. So, Professor O'Donoghue, are the effects in the kidneys and liver because they have a lot of blood vessels in them, or is the virus attacking them directly? And are these treatable, or are we going to have to go into much more radical treatments in larger numbers, like dialysis, and a much bigger demand for transplantation? And are we prepared for that?
That's a great question. So the kidney does have the receptors that the virus would have affinity for, and there is some work to suggest that the virus does affect the kidney specifically. But most of the post-mortem studies and most of the opinion now is that people are developing their kidney injury really on the basis of the systemic disease that they're getting. So normally we see, maybe 20% of people that go onto intensive care unit need to have, a form of dialysis. During COVID, it was up to 40%, and 85% of people had some degree of kidney injury. No doubt that's happening out in the community as well, probably to a lesser extent, but no doubt it's happening out there. And from a kidney perspective, that's the unknown as to, well, how many of these individuals will then go on to have more severe kidney disease as a consequence of having that initial insult. The data looks like a third of people who survive will have some degree of kidney impairment, and if even a small percentage of those go on to have progressive kidney injury, there's two or three imperatives. The first one is to do everything we can to slow down that disease process, which isn't rocket science, but does need to be identified and treated and managed, blood pressure control and so forth. Two is to be planning for the increase, because it could be, it could easily be tens of thousands more people requiring dialysis transplantation. In a normal year, we'd accept around about 6,500 people onto dialysis and transplant programs. So you can see the order of magnitude, and it needs to be modelled out and then worked through. And then the issue about including people with kidney disease in trials. So we've got the ludicrous thing that people are excluded from trials, yet they're the highest risk, and they're excluded from trials because somebody's thought, well, we don't know how to manage this drug if there's reduced kidney function. And things like hydroxychloroquine, which is a treatment for lupus nephritis, for a kidney condition, people are excluded from trials of chloroquine because, that make it more complicated. So as I said in the introduction, 45% of people with kidney disease, 45% of trials exclude people with kidney disease, and yet these are a very high risk population that we can learn so much from.
Thank you. May I ask my more general question, please? Which is, given what all our witnesses have said this morning about the long-term effects of the virus, even many of them amongst those who've had mild symptoms, is the idea that we could encourage herd immunity by allowing a lot of less vulnerable people to get it a much more dangerous strategy than it at first appeared? And should we be messaging younger people who are pretty confident they won't get seriously ill, that they may have some very nasty long-term effects afterwards?
So I'll give a short answer. Yes, it would be foolish to go down that route for all the reasons we know now about the consequences of having had COVID and how they may play out. And of course, we don't know. We don't know what the consequences will be in younger people. So we've got a fairly good idea in children, but we all know of friends and relatives that are, we think of as relatively young and are relatively young, who are having serious problems, and what the long-term consequences, might be neurologically, cardiovascular, renal wise. I think, we just don't know. One would be much better to go down a vaccination route, I think.
Thank you. Do either of the other witnesses want to comment about that?
Just a brief comment. I completely agree that we have no idea currently what the long-term effects might be. There are viral long-term effects that we can't even predict now that might come up in 10, 20 years. Neurodegeneration has been a problem in previous pandemics, the very famous 1918 pandemic, which caused Parkinsonism, and there are long-term effects on the aggregation of neurodegenerative proteins. We don't know this. I've been involved in other studies, completely unrelated to COVID, over the last 15, 20 years, where it turns out that pathogens, specifically aggregated proteins, can be transmitted in a way that we had no idea about 20 or 30 years ago. Currently, this is not a problem anymore because practices have changed. I just want to say this could happen again with a completely new pathogen that is untested and relatively preliminarily characterized. So we should be, I agree that vaccination programs are probably better than trying to rely on a herd immunity, which may not even happen, because if the immunity ceases after a certain period, then we're starting all over again. So vaccination seems
okay. Yeah. Thank you very much. Lord Winston, I saw you nodding there. Lord Winston, your question.
I'm very concerned that we've completely missed one very important part of healthcare, which is not the fault of our witnesses, but perhaps our fault in a way, and that's women's health. There are, in the United Kingdom, some 700,000 births annually and a good deal more pregnancies than that. And one of the issues is, what are the long-term effects on the fetus, given that during the time of the pandemic, a large number of fetuses would have been at the time of the when there is development of organs, organogenesis, certainly at the beginning of organogenesis, and we know with other viruses that does have an effect. Would our witnesses perhaps give us any kind of help on where we might find out about what follow-up is being done on those pregnancies, and whether or not, for example, there's any post-mortem material on the products of conception of women who've miscarried, and what we know about perhaps the brain in fetuses which have died during the pandemic. Thank you. Can I start with Professor O'Donoghue, perhaps?
I was going to defer to Professor Solomon.
I thought you might.
So well, let's go straight to Professor Solomon rather than me waste time.
But Professor Brandner might also know about pathology. So anyway, Professor Solomon first.
I think I can help a little bit, because our unit, we were heavily involved in the Zika global health emergency, which, as you know, did have severe impacts on pregnancy and on newborn children. So I think the first thing to say is that there has not been any great signal in this area. In other words, we've had many pregnant women infected with the virus, and there are not any of the obvious, very severe problems. I shouldn't say not any. There's not a large number of the obvious severe problems like there were for Zika. So we're not having hundreds of children born damaged. Whether there are more subtle problems we would not yet know, but there are studies looking at this. The committee I was chairing and co-chairing have funded work in this area. So there are registries looking at children born during this time period, including some work led from a colleague of mine here at the University of Liverpool, Professor Louise Kenny, who has an interest in this area. So it may have been your committee may have overlooked it, but it's not been overlooked completely by the scientific community, and we are looking.
But the reports that have been published does not suggest the same degree or any degree of vertical transmission at any stage.
I think there are a few reports that suggest something, but there always are. You know, if you've got 300,000 people in the UK known to be infected with the virus, there's always going to be a small signal. But I don't think there's a dramatic signal that suggests this is a major issue at the moment.
Professor Brandner?
So, yeah, I have been also very interested in finding postmortem material of children. So I have liaised with my colleague at Great Ormond Street Hospital, a pediatric neuropathologist. And what we agree, there's a very small number of children that have died. There is no child, to my knowledge, that died of COVID-related complications. But to my knowledge, there is very limited material available, and I can't really comment further what might be realistically available for further studies.
Okay, thank you very much. Lord Winston?
Of course, one of the issues also, which is not included in this half of the session, is, of course, what happens with the care of women who have their respiration and cardiac function in a very different position during late pregnancy. So we can't really ask you those questions, but it would, I think, be useful perhaps just to consider that a large number of viruses don't kill the fetus, but they certainly may result in abnormalities in the fetus, which are not always described or noticed till later on. And I think that is something which really, I mean, obviously, I know I'm not supposed to give an opinion here, but it would be helpful to hear from you and perhaps from Professor O'Donoghue whether you feel that this is an important area for us to make sure is being followed up in public health.
So I do think it's an important area, and I can seek the views from the obstetric physicians who would have, more handle on that.
Well, there are two on the committee. Anyway, carry on, Professor O'Donoghue.
No, so I say I don't have expertise in that area myself, and I'm not cited on the details. So I think it's better that I send information through to the committee rather than speculate.
I think the question Lord Winston was asking: do you agree that we should, in whatever we say in our report, should include as part of a long-term data that should be collected, should relate?
Yes.
Yeah.
Yes.
Thank you very much indeed. That really, I think, covers my question.
Okay. Baroness Young?
The questions I was going to ask have pretty well been answered, but they do raise another question, which is if we're predicting a as yet unsized uplift in long-term morbidity, ranging from fatigue right up to serious kidney and other damage, is anybody out there, are you aware of anybody out there who's actually planning for dealing with this in the way that you described, i.e. in a multi-morbidity integrated way, which includes physical and mental health? Is the NHS planning to cope with this, or is it being dealt with piecemeal at a local level?
So I think it'd be fair to say that people are just getting by with the second wave, perhaps starting and trying to maintain the services that have been brought back and manage a workforce that has been fairly battered with things. So it's not there. I think there is some very good research that is being put in place, and we heard a little about that in the last session. But it's excluded some data sets. So the kidney, it's not linked to the renal registry, and there's a great opportunity to link our data sets, which will tell us things that we can then model for and plan for. And I think that is something that we very much should do. The service model, I think, is something that needs to be challenged. And I think the only realistic way that we can put in a service model to monitor and support people is one that is actually holistic, because otherwise we've got 3 or 4 people involved in each individual's care.
So Professor O'Donoghue, as an officer of a professional organization, do you think the professional organization should get together to thrash out what kind of services will be required for people who have been infected with COVID-19 and the problems they will suffer in the long term?
Yes.
So that might happen soon.
I hope it will. I think we are working in that direction, but anything that can be done to support that, I think, can be helpful.
Okay. I have Baroness Blackwood and Baroness Manningham-Buller for a quick question. Baroness Blackwood?
Thank you, Lord Chair. I actually wanted to follow up on the question from Baroness Manningham-Buller earlier about research gaps. And I did wonder if the witnesses knew if there were any plans or thought there was any value in comparing the long COVID cohort, which is emerging, with other post-viral and chronic fatigue syndrome cohorts, and if there were data sets that were relevant, and if this would be valuable in understanding how to go forward.
I think that's a really interesting and useful comment. I mean, we're in a sort of emerging area about this long COVID cohort. And there are some people who feel very strongly they don't want to be grouped with this idea that this is a post-viral fatigue syndrome or chronic fatigue syndrome. But I think comparing patients can always be helpful, and it can help guide services, therefore, accordingly.
Baroness Manningham-Buller?
Thank you, Lord Chair. I wanted to, it may be that our witnesses can't answer this question, but I really wanted to follow up question.
Can you come slightly nearer to your computer?
It may be that our witnesses can't answer this question, but I'd like to follow up something that Lord Ridley asked, which is really whether we yet have any data on suicides or in-hospital admissions for those who actually haven't had the disease, as far as they know, who are deeply affected by it mentally.
Professor Solomon.
Well, my understanding is that looking at such data, particularly hospital admissions, is not. It's difficult to understand quite what that means, because hospital admissions across the board were reduced at the start of the pandemic, and then and so I think just looking at hospital admissions is not necessarily going to give you an answer. I think there are data now. There's quite a bit of data now showing COVID-19 is associated with increased anxiety and depression, etc. And I think there are some data on an elevated suicide risk, but I'm not completely sure of those. And Lord Winston was talking about perhaps gaps in the remit of this group so far. And I don't know if you do plan to have somebody with real expertise in mental health talking to you.
Yeah, we have sessions next week on mental health.
We do, good.
Okay.
Yeah.
Okay, Baroness Manningham-Buller, do you have any others? No.
So that was the main one I was interested in. Really, the people who didn't have COVID and the effect on them. But I think, as you say, Lord Chair, we'll come to that next week.
Okay. Thank you very much. I got only 2 minutes left, so if I could ask a very quick question and a quick answer. It seems to me, from the discussions we've had, that there are considerable gaps in research, and particularly data collection that will be required for follow-up and research into the follow-ups, and service gaps for patients who have suffered from COVID-19 and survived, but will still continue to suffer because of organ damage. Would that be a good summary of it?
So it will be a good summary, but it misses out the missed opportunity to link the data sets that we do have and to address the IG issues that could allow that. So I think we've got the great data, but some of it is still in silos. But we have key issues in terms of the systematic follow-up of people.
Okay.
And I would like to add that the final outcome of a small number of people with neurological complications is obviously that they die of these conditions, and it would be very useful to encourage everyone involved in the consenting and requesting postmortem procedures to ensure that we get material to investigate. Without postmortem material to investigate the effects of COVID-19 on the brain, it will be much more difficult to link definite postmortem data with all the clinical data.
Okay, thank you. Professor Solomon, do you have any comment?
I think you've summed it up very nicely. I think there are service gaps. I think this does present an opportunity, though, to think about how we might do service differently. And these clinics where we have multiple input, we're not necessarily talking about 6 different consultants sitting together. I don't think that's ever going to happen. But I think what we're talking about is using the opportunity. If a patient comes because of a renal problem, that may be the opportunity to provide extra input on their breathing and how they're coping with that. Are they coping with fatigue and stress? Are there other issues? So it's joining the services up in that kind of way.
Yes, thank you very much. The Professor Brandner, the question that Lord Kekar had asked in the last group was about whether enough tissue material is collected from patients who mostly presumably died from different organs to be able to have that tissue material to do studies in the future, including for medical treatment development.
I think there was indeed a very significant effort on many sides, and there are some amazing tissue collections. But I think given the scale of the problem and the scale of the disease and its variety, to capture the more rare events and study them properly, I think more could be done to close those gaps.
Thank you very much. Well, thank you very much, all three of you, for helping us today. It's been a very interesting session. They all have been interesting. But thank you indeed very much.